My name is Jacob Strand. I'm a physician at the Mayo Clinic, at the Palliative Care Service in the Department of Internal Medicine. I co-wrote the article with Dr. Andrew Billings in the How We Do It series entitled Integrating Palliative Care in the ICU for the Journal of Supportive Oncology. One of the most common misconceptions palliative care clinicians can have about ICU personnel is somehow that the patients we're consulting on have had inadequate attention to pain and suffering, or that prognostic information and family communication haven't been adequately assessed. Some people have talked about this like palliative care clinicians entering in as saviors into the intensive care unit. My co-author, Dr. Billings, wrote about this as akin to bringing truth to the unwashed. And I think that this type of misconception and attitude can sometimes really fail to recognize the critical role that ICU care teams have been playing in the care of these patients and the experience they have at taking care of critically ill patients at the end of life. One of the traps that palliative care clinicians can fall into when seeing patients in the ICU is really assuming that patients haven't had adequate attention to pain and suffering, or that communication around prognostication or family understanding hasn't been adequately assessed. Certainly this idea of palliative care clinicians entering into the ICU as saviors is something that can be encountered. Dr. Billings, my co-author, has written about this before, that it can be akin to bringing truth to the unwashed. I think unfortunately this ideology and this mantra can neglect the critical importance that care teams in the ICU are already playing in the care of ICU patients. Similarly, the ICU care teams bring tremendous experience and viewpoints in the care of patients at the end of life. One way to address this is to adopt an appropriate curiosity and empathy towards ICU care teams. Certainly this is one of our most important roles in the ICU, is to provide support and empathy as ICU care teams care for very complex patients, very complex emotional situations, and very challenging family situations. Another trap that palliative care clinicians can fall into when encountering patients in the ICU is failing to appropriately assess the culture and the differences about the various ICUs that they interact in. Certainly medical ICUs versus surgical ICUs, cardiac ICUs, transplant ICUs. All of these different environments have different histories, different cultures, and different experiences at dealing with patients at the end of life. It certainly is our job as palliative care clinicians to assess the culture, assess the environment, and then find receptive clinicians, allies in nursing and social work that can help us integrate and show the benefits that we can provide in these settings. Some of the most common triggers include finding those patients at greatest risk for morbidity and mortality, as well as those patients at greatest risk for post-ICU mortality and at-risk bereavement. Some of the most common triggers include patients with advanced dementia and Alzheimer's, patients with global cerebral anoxic brain injuries, and those patients with stage 4 malignancies. Patients with stage 4 malignancies in the past hadn't been considered in the same group potentially as these other high-risk populations. But certainly current research shows that these patients have a tremendous risk, not only during their ICU stay, but also in the time after their discharge, should they survive to discharge. Some recent data looked at lung cancer patients who were admitted to an intensive care unit and found that their survival rates at 6 months ranged anywhere from 11% to 32%. Certainly patients who could use a more proactive approach to palliative care. One way that these triggers can be integrated is also to have palliative care clinicians involved either in a pre-rounds, where they meet with the ICU team to go over patients that may benefit from palliative care consultation. Another way to integrate palliative care earlier in the care of patients in the ICUs is to utilize a palliative care clinician pre-rounding with ICU teams, identifying those patients meeting the triggers and who may benefit from palliative care consultation.